Good afternoon and welcome members of the press. As of today, 66 countries have officially reported greater than 19,000 cases of influenza A H1N1 infection, including 117 deaths. Globally, WHO acknowledges there appear to be three patterns of H1N1 viral spread. The first group of countries includes the countries of Canada, the United States, and Mexico, where there are large number of cases occurring, but there's a mixed pattern of spread, where in some communities spread is increasing, in other communities spread is decreasing, and while in other communities it's increasing after having already decreased before. So this is a mixed pattern of spread. Second, there's another group of countries that we call transition countries. These countries are reporting large numbers of cases, and they're also reporting early spread into the community. And finally, there's a third group of countries that have limited cases that they are reporting, and these cases are largely related to travel history. WHO calls this outbreak moderate rather than mild for three reasons. We know that the infection can be fatal both in those with underlying chronic medical conditions and in perfectly healthy individuals as well. We know that overall the number of serious and fatal cases is limited. However, we do not have a complete picture yet and do not know with any accuracy how many people are infected or seriously ill. So this gets to the problem or challenge of identifying the denominator or the total number of those ill. And thirdly, WHO has taken all this to mean that we should expect outcomes similar to the pandemics of 1957 and 1968, for example, when in excess 1 to 4 million people may have died in each of those pandemics. There are other reasons why experts argue this is a moderate outbreak. The secondary attack rate, particularly in schools, where that is the percentage of contacts exposed to an infected case who then become infected, may be as high as 33%. This is higher than seasonal influenza. In terms of clinical severity, in the US and Canada, 2 to 5% of the patients infected required hospitalization, and this number was 6% in Mexico. Of all the deaths in Canada and the United States, 2/3 have occurred in individuals with chronic underlying medical conditions, and in Mexico that number is approximately 50%. We know that in many developing countries, we just don't have the capacity to respond to the outbreak in the same way countries with more resources have been able to respond. Future impact remains uncertain, particularly over the next few weeks in the South. We will need to see how this virus evolves in the Southern Hemisphere over the next few weeks, and then in the Northern Hemisphere in the upcoming fall. The best scientists and doctors in the world are working on this, but they cannot predict what is going to happen. Preliminary evidence suggests that the virus is displacing the seasonal virus in the southern cone countries of South America. So the bottom line is that we cannot be complacent. What may be happening in Chile is what happens with the usual evolution of a pandemic. In Chile, where the winter flu season has just started, a great proportion of the cases being reported are caused by the influenza A H1N1 virus and not caused by the traditional seasonal virus. In the usual pandemic situation, the pandemic virus actually replaces the seasonal virus. We need to monitor this carefully because we also know that when the virus is circulating with other seasonal virus, there's a risk for changing. So this must be monitored. At this point in time, we remain in phase 5, but we're becoming very close to phase 6. Given the fact that we are getting closer to phase 6, WHO held consultations 3 days ago on June 1st with over 30 experts from 23 countries, as well as experts from WHO country and regional offices around the world. And they met to discuss the concerns and needs of countries as WHO prepares to get closer to defining and declaring phase 6. The consensus arrived among this group of experts was the following. WHO will continue to use geographic spread for phase 6 definition. There was overwhelming consensus, however, from all the experts to add an assessment of severity as well, and to provide countries with guidance on how to construct severity scales that are relevant to countries' specific contexts or situations. It is difficult to assess severity, but such an assessment must reflect the virulence of the virus, the prevalence of risk factors related to the individual host, the vulnerability of populations, and countries' resilience or capacity of the health system to cope with the rapid increase number of H1N1 patients. To that end, WHO will provide a global assessment and guidance which is useful for countries and can be adapted to local needs. Severity will also vary over time and between and within countries, so this assessment must be flexible and reflected. As a result of all this, the next steps for WHO will be the following. As a result of this consultation and other discussions, WHO will finalize measures to assess severity and will provide simple, accessible guidelines to countries to help them prioritize and calibrate their actions. WHO will also help the public to better understand the meaning of phase 6. WHO will coordinate such work with the International Health Regulations Emergency Committee. Examples of actions that WHO would not recommend countries to undertake include the following. No trade restrictions on or killing of pigs. No travel restrictions or closure of border areas, to name a few. PAHO looks forward to continue to work very closely with its key partners such as the CDC of the United States Health and Human Services Department, the Public Health Canada, and other organizations to provide the best technical cooperation possible to our member countries. So thank you. I'll end there and take any questions that you may have.
Thank you, Dr. Andrus. Do we have any questions on the phone lines by conference call? No. Okay, the moderator tells us there are no questions via phone, so we do have some questions via email. Doris Gomorra from El Universal in New Mexico asks, with the beginning of winter in the southern hemisphere, there are a lot of new cases in some countries such as Chile. I was wondering if PAHO has any kind of projection of the H1N1 epidemic in that hemisphere, and how many Latin American countries are interested in new vaccines, and also if we know how many have already signed contracts with manufacturers for new vaccines.
Very good questions. I begin by saying that it would be a mistake for me to predict or project what will happen in South America. I can come up with some possibilities that are likely to happen, and the evolving case of Chile is very instructive. As I mentioned in the presentation, there are increasing numbers of influenza cases during a time when we would expect increasing numbers of cases to occur. That is the winter season of Chile, when they have their normal seasonal influenza pattern. But when we look at the isolates, when we look at the laboratory diagnosis, the vast majority of these cases are the H1N1. So it appears at the early stages of their winter seasonal influenza season, the H1N1 virus is emerging. And that would be likely to occur in other Southern Cone countries. The conditions that exist in the Southern Cone countries, the cooler, less humid conditions, and where people would tend to congregate to stay warmer, are conditions that promote the transmission of the virus. We know that probably virtually all countries, I know of one exception in our region, are very much interested in a vaccine if it becomes available, if and when it becomes available. And yes, there are countries that have pre-production contracts. I don't know the number, and generally those are countries that have more resources to do so.
Okay, thanks, Dr. Andres. We have two questions from Argentina, El Diario El Liberal. The second one is related to what you were just discussing. He asks, considering that the strongest impact in the northern hemisphere of this H1N1 occurred in the summer, is it possible that in the southern hemisphere the impact of this virus will be stronger than what has already been seen so far in Mexico or the United States because of the fact that the disease is arriving in the winter?
Yes, that's a concern for reasons I mentioned.
Okay. And then his other question is, in Argentina, schools have canceled activities such as study trips, sporting activities between institutions, or other events that imply great numbers of people, conglomerations of people. Using this criteria, is it recommendable, or should we recommend that that we do social distancing measures for things like discotheques, considering that here we are almost in winter and discotheques and similar places are usually places with closed doors and a large concentration of people? Should these measures be applied for other kinds of localities as well?
It's a very good question, and it relates to the issue of social distancing, those measures of mitigation that will help slow down the spread of transmission. And I think I should state at the beginning that any recommendation should not be a cookie-cutter type approach to a country, that the recommendations and the actions taken should be based on the local conditions. What we have found in countries that have early cases generally related to travel, in situations that, for example, involve schools, it may be appropriate to close schools. That has been done, and for good reasons. But it may not be appropriate in other situations where transmission is more extensive, and recommendations to cancel mass gatherings may not be as appropriate. So it gets back to the fact that this virus and the outbreaks that are occurring as a result of this virus is a moving target. So every situation should be addressed based on the local conditions. A general school closure recommendation in a country probably would not be useful for the country. You would have to look at each individual school situation and based on that assessment then make a decision.
Okay, thanks, Dr. Anders. Joel Hernandez of Mexico asks, do we know where the very first case, I guess you could call it the index case, of this swine influenza appeared?
The answer is no.
Okay, pretty straightforward. And Rodrigo Lloredo asks, what are the preventive measures in coordination with local governments that are being taken or should be taken to avoid collective psychosis in countries where there's little information about this theme?
That's a great question. When I heard the first part of the question, I was ready and on the edge of my seat to respond with the usual recommendations that focus on hygiene, frequent washing of hands, the use of tissues to cover sneezes and coughs, and social distancing. The second part of the question related to the collective psychosis that he mentioned really relates to the capacity for a community, for a province or state, and for the country to provide the appropriate communication messages. And I think all those messages should be grounded in transparency, should be grounded in developing trust, should be grounded in honesty by explicitly stating when we know something and when we don't know something. And that way the public can develop a sense of trust and confidence that would prevent the risk of such things as collective psychosis.
Now we have Margarita Vega from Reforma in Mexico, who asks, in the classification that you gave at the beginning of the conference, where we have different kinds of patterns of spread, in which pattern do we find Mexico? Do we consider the epidemic controlled in Mexico, or do we fear that it could resurge?
Mexico is in the first group of countries where it's a mixed pattern. Overall, Mexico is reporting fewer cases by week, but there's still cases, there's still circulation occurring. And when you go down to the community level, you'll see the mixed pattern that I referred to in that first group of countries. Some communities have already had their outbreak, and so the susceptible population has been exposed or infected, so you'll see declining numbers. In other communities where the virus is yet to reach, you'll probably see or expect to see increasing numbers. And then again, we're seeing this other phenomenon, as has happened in the United States, where community reported declining numbers when only to begin seeing increasing numbers after that decline. So it's a mixed bag, and it's very, very difficult to generalize either from the province, state, or national level.
Terra Network in Chile, Andres Varas asks, would we consider the case of Chile explosive because of the high number of infected people that have been reported there? Or can we explain this because we have high detection capacities in Chile? And he adds a second part, which says the Chilean authorities yesterday warned that the cases could reach 4,000 and that in 3 weeks from now they would reach the peak of the epidemic in Chile. Does this coincide with our projections? And in general, when do we expect the peak of the epidemic to be reached in South America in general over this winter?
Those are great questions, but having listened to them, I hesitate to predict. It gets back to the fact this virus is so unpredictable. I think the messaging in Chile was to alert the public to the fact that they're early on in their flu season, so a voice of reason, a common sense would say, yes, we're going to see increasing numbers of cases. But for me, here sitting in Washington, to project the numbers of cases over so many weeks of time, when will it peak, I really would hesitate to do that. I think the real message is the importance of monitoring this, because we know that a greater proportion of the cases coming out of Chile are being identified as being caused by H1N1 virus, but there's still a proportion of cases that are being caused by the regular seasonal virus. And when you have communities with a mixed pattern of transmission like this, there's always that risk of the virus recombining and changing, in part due to that recombination. So I'll stop there.
Celia Carvajal from Agencia Telam in Argentina asks, which pattern of propagation fits the case of Argentina, of the patterns that you mentioned at the beginning?
It seems at this point that it would be in the either somewhere between the second group of countries or the third group of countries. At this point in time today, I don't have the most accurate handle on the number of cases in Argentina, but I would venture to say that it's somewhere between those two patterns.
And then another question from Mexico, from Joel Hernandez Santiago. Why, in the case of Mexico, were there such large numbers of deaths from influenza, and why has this not occurred proportionally in other countries?
It's a great question, and it's one that we come across frequently. As of today, we know that in Mexico, 97 people died during the outbreak. The deaths were discovered due to the initial surveillance attempts to try to identify the severest cases. That was a decision made by the Ministry of Health at the early onset when they identified that there was a problem. They decided that we should go out and prioritize those that were presenting with the most serious disease. So they focused on their hospitals and very rapidly identified a number of deaths. But to put that against the denominator data that I mentioned, that is to put that numerator, 97, over a total number of cases, a total number of people that have been infected, is difficult, and explains in part why we see different rates such as this. So with that, it's difficult to go back and retrospectively, with great accuracy, define that denominator. Having said that, though, even in Mexico, the estimated case fatality ratio with the best data available is less than 1%, as it is in the U.S. and Canada. But I think that's about the best answer I can give to that. It's a difficult question to accurately address, because at this point in time, we really don't have the kinds of information that would accurately determine that denominator, that is, the number of people that were actually infected.
Okay. Angeles Cruz from Mexico asks, how can we explain that in the northern hemisphere, where we are already starting the warmer months of summer, we are still seeing transmission of this virus?
It's a good question. I think that translates to some properties of the virus that we have learned over the course of the outbreak. The infectiousness of the virus, as I alluded to in my presentation, is greater than the seasonal infectiousness, and we look at that in terms of secondary attack rates. There's good data particularly from school situations, as I mentioned, that those secondary attack rates may be as high as 33% with this current H1N1 virus. So that translates to the fact this virus is more transmissible in communities, and with that will infect more people and then be able to establish itself over a longer period of time. There's another measurement of this transmissibility or infectiousness that I did not mention, and it's called the reproductive rate. I won't go into the details, but it does measure with the best epidemiologic data available the rate that basically what it translates to is if I'm infected on average, how many people do I infect in the absence of measures of intervention? And it is higher than the seasonal influenza, so that's another indication of why it can persist longer.
Then we have a group of questions which are similar in intent, and I think we can turn them into one question, which is really about preparations. How well prepared are specific countries in South America, and more generally the international community, for a new outbreak or a pandemic of influenza?
I should start by saying flatly that we're probably no better prepared than any time in history, and that relates to the fact over the last 5 years so much work has gone into preparing for the bird flu pandemic that scientists were expecting. That was the H5N1 virus that caused sporadic cases around the world, and recognizing that the case fatality rate of that H5N1 bird flu was 60 to 70%, meaning that of all the people that got infected with that virus, 60 to 70% of them died. So it was a very serious problem, and basically catalyzed all this work that went into the last 5 years of getting prepared. That translated into countries meeting and conferences, workshops, producing plans of action, preparedness plans, enormous amount of training, support that developed better surveillance, both nationally, subnationally, but also regional networks, and better collaboration with our partners. So that I can say that flatly, but that development of capacity to respond will vary by country and also vary within countries. So we have countries that require more support at this time, even though they may have a plan of action or emergency plan, as I referred to. They will need more support, particularly with diagnostic capacity, and to that end, there's been a great deal of work with our partners, Public Health Canada and CDC, to support them, from sending teams of experts to countries, to producing the reagents required to making the diagnosis, the test kits, and so on. And then I haven't even referred to the amount of work going into preparing a vaccine, another enormous area of work. The work that PAHO and WHO has done to provide the antivirals, and so it varies by country and also with communities within countries.
Okay, and that segues nicely into our next question from Abida Alham of Trinidad, who says, how close are we really to developing a vaccine?
4 to 6 weeks ago, we said 4 to 6 months, so we could subtract that to that time frame, and that's how close we are. We're very, the virus, the seed candidate vaccine strain viruses have been made available, and companies are working very hard to produce vaccine virus.
And then we have another question about people. What is the health situation or the health conditions of people who have been infected by this new influenza virus? Does it have sequelae that are different from those of seasonal influenza, or does it have any serious long-lasting effects?
It's a great question, and there are probably different ways of approaching that question. I think the first thing that comes to mind is the fact that when you look at older people, particularly older people with chronic conditions, and you have something that is a challenge to their health, basically something that insults their homeostasis, the balance or well-being of their health, given the fact that on a day-to-day basis, they may have heart disease, they may have diabetes, they may have chronic obstructive pulmonary disease. when there is that insult, it will, even though they recover, it throws them off track so that they're at risk for a longer period of time, perhaps months, if something else were to happen to undermine their health status. They would be at greater risk of succumbing or dying to that second insult. So that's something that we don't often see in general public health surveillance, but it is a fact that clinicians see when they take care of individual patients. So that's something that this virus potentially has to harm people. There have been epidemics. The 1918 epidemic is the classic, that sequelae, people who were infected in that epidemic were likely to develop Parkinson's as they got older. So we know that's a medical fact, and that is a sequelae. We don't know, though, we can't predict that will be a problem with this particular virus. But I think those are two examples of how I would look at this in terms of sequelae. Getting back to the first example, any person that has an underlying medical condition, any pregnant woman, and young children are at greater risks for the ultimate adverse event or sequela, which is death.
Okay, and then we have a question from Executive Intelligence Review, Cynthia Rush, who says that prior to this outbreak, the factor of severity wasn't part of the criteria used to declare a pandemic. What caused WHO to change the criteria? Shouldn't phase 6 already have been declared? And she says she understands that at the last annual conference of WHO, the British health minister was key in demanding that the factor of severity be included in the criteria for a declaration of a pandemic, and is that the case?
That's a great question, and it's a question that comes up frequently in our daily international global teleconferences with WHO, with the WHO regional offices and country offices. This is something that Dr. Margaret Chan has addressed and has gone out some weeks ago during the World Health Assembly to discuss this issue. Another example, I think, that highlights that the nature of this ongoing discussion some weeks ago, the Asian countries met, the South Asian countries. There's an organization there called ASEAN, and that was one of the recommendations coming out of that group of South Asia countries. She also had consultations with other countries from Asia, such as Japan and others. It came up during the discussions at the World Health Assembly, and for that reason, this consultation was held 3 days ago. So it's been ongoing, and there are experts who believe that phase 6 should have been declared in the past. I personally can't argue with them, but the general consensus, I think, from most experts, particularly from those that participated in this conference call 3 days ago, was that we should stick to the current criteria, geographic spread, but then include this scaling of severity that would allow countries to take the appropriate measures based on their local conditions.
Okay, then we have one more country-specific question in which Rodrigo Loredo asks, to what factors do we attribute the reduced number of cases in Bolivia? And I'm not sure we have an answer for that.
I don't have an answer for that. It always raises a concern about the capacity to monitor and develop the surveillance, but I know that PAHO has sent consultants to Bolivia, so the fact that consultants have been there to help with the laboratory support, and if they're not reporting cases after that, I would be surprised. So, but my understanding is that there has been a team that a week or two ago was deployed to Bolivia to help them bolster their surveillance.